Hi, everyone, and welcome back to our public health career conversations. And today I am pleased to have with me Dr. Chriselda Pillay, who is a public health medicine registrar in UCT. So she is still in her training, but I think it is valuable for us to understand from people who are still joining the field exactly what the process has been like in deciding, what the journey has been to date, and how they are currently experiencing public health as a field that they are currently training in. So welcome, Chriselda, and thank you for joining us today.
Thank you.
All right, so as I've said to everyone, you are a public health medicine registrar, but as I understand from our previous conversation, you are not completely new to the field. So let's start with currently, before we get into your journey, let's just maybe unpack a little bit more around what made you go into public health, what was some of the thinking around it, and what were some of the decisions that you had to make as you moved forward in your career?
Sure. Okay, so I was fortunate enough to have my ComServe at a lovely district health facility with a very close community where I got to experience, the principles of COPC and really see them in action. And so after ComServe, I stayed on as a MO at a district level facility. And in that time, became very familiar with the people, their families, the needs in that community, and becoming quite disillusioned by putting plasters on the same kids, putting pops on the same kids, and then this week it's a pop, and then next week it's an accidental ingestion, and really just that revolving door of things that could be prevented from a systems level. So already in that clinical time, I was very interested in, okay, but how do we stop this from happening to this group of vulnerable people? And then COVID came along. And I was in my third trimester of pregnancy when it was the first wave. And so I had the opportunity to do remote case management. And in that time, I found a space that I was very interested in, where we were looking at really working beyond the scope of health. So yes, we're checking up on you. You have these comorbidities. We've identified your risk. I'll give you a call. I'll go through your health assessment. But also from a social determinants of health perspective, I understand that you can't isolate in your dwelling space. So how can I help you with that? I understand that if I'm asking you to stay at home and to not explore your means of, earning an income, you're going to be struggling with getting food on the table. So can we support you in that way? Can we deliver your chronic meds instead of you coming to the facility? And that really, really inspired me to take that next step. So I had a chat with my mentors who were family physicians who really held the space as facilitating this project on a bigger scale, the management of COVID positive patients. And the advice was, well, Chriselda, if you want to do this, I would consider public health. And so I had a few conversations with them, and the advice was, one, go towards the MPH first, the Masters of Public Health, because in that way you're not committing yourself to a full program. You can still do this while you're in the service, and there's sort of no strings attached. You can do a few courses and then you can decide. And the other bit of advice I got was, having some research experience is also quite helpful. So at that point, I wasn't able to get into the MPH because it was too late in the year, but I did notice that the University of Pretoria offered an online diploma. And to make sure that this is what I wanted to do, I took a few of the sort of base courses through them while I was the end of my mat leave and then start returning to work full time. And then I was certain the projects, the content, the far-reaching scope of the work. This is what I want to do. And yeah, that's when I decided, okay, I want to do the MPH. And I was fortunate enough to be able to leave the service as a MO and took up a post as a research MO at UCT. And that allowed me the time to put into my Master's of Public Health and the practical experience where I was incredibly fortunate in terms of projects and writing up research reports. I was really able to apply what I used.
That's awesome. So I just want to say I also started my public health journey in family medicine, also as a comm service MO in the district health system. And yeah, it's very interesting the way, I know a lot of people confuse public health and family medicine or primary care. And so, but I think there are synergies between us, and that's that's where we probably get exposed quite easily to the social determinants, as you say, because you are really within communities and working with them. So that's very interesting. So, I mean, you've run the gamut in many ways of public health. Yeah. So you went on to do your master's in public health, and then obviously you're specializing now. So maybe just talk me through what you actually did within your master's. Was there a specific stream, or did you sort of general master's? And then what was the decision then to go into the specialization? And the reason why I'm asking this is because a lot of people have differing experiences, especially as medical doctors. So I did my master's as well before my specialization. And for me, it was the difficulty in translating the master's into an actual job, because I didn't really have the practical experience. Whereas you were fortunate enough to be working in such MO position. I was working in clinical medicine still. So yeah, maybe just talk around that, because I think that's what a lot of people are trying to figure out, is like, do I do the master's? Do I do the specialization? And maybe your reflection on what you see the differences are, or how they were different or similar to you.
Sure. And I can speak to specifically how UCT structures its MPH program, because that is what I'm familiar with. So the Master's in Public Health is organized into different streams. And the advice was that if you are going to consider going into the registrar program, the requirement would be that you would have to do the same modules as an MPH student would do under the epidemiology and biostatistics track. So there are certain core modules that cover those learning areas. And there's a little bit of play with, I think, about 2 or 3 of them where you can choose between certain modules, but, sort of still addressing the core needs of what you would need to know. So that's what I decided to do. It is a lot of work, and I will say that with appreciation for colleagues who remain in the service and want to explore that part-time alongside their service requirements. I would definitely, set sights on not trying to finish it in that 2-year. You have the option of 2 to 4 years. I would not put the pressure on yourself to finish it on 2 years. That was more for people who were out of the service. And also the beauty of the MPH is that you get to link up with people who are outside of the traditional medicine clinical space. So we had colleagues who were in finance, who were in law, a few veterinary science colleagues. So, speaking towards the One Health needs, we were quite a varied bunch. But with appreciation for the, my colleagues who were in the service, they took it at a slower pace, maybe took 1 or 2 modules per semester, as opposed to the rest of us who had capacity to take on more. So yes, they are different streams, and they speak to different needs in terms of, if you're taking more of a social science perspective, if you want to take more of an environmental health perspective, there are modules that speak to those different areas. But for the purpose of wanting to go towards the registrar program, if you have a look on what the college requires, there is alignment between the epidemiology and statistics track and what the college requires you to know for the exam. And so that is the suggestion. So a lot of biostatistics. We did, there's 3 biostats modules, 1, 2, and 3. We did basic epidemiology, so a lot, starting off with what we've covered in med school, then adding a bit more to it, and then taking it on further to, you can take advanced epidemiology as well. And then, filling in the gaps in terms of evidence-based healthcare, how to, quantification in terms of non-communicable diseases and communicable diseases, what the epi looks like across those different groups. Yes, and then there's options for practicums, which is very exciting, and something that you can take advantage of if you find something that aligns with your interest. Perhaps you're working at a primary healthcare level and there's a need for HIV and TB, a response to a certain need. And, our colleagues might put out, or, in the department, that they are willing to run a practicum, and you can link up with them and you can work on these projects. And it is amazing for experience and stakeholder engagement, and just getting a taste of, what it means to be embedded in a community and to put out a product that's actually meaningful at the end of the day. It's a nice little taste for that. And one last thing, the MPH also includes a mini dissertation. So as you work through the modules, you will learn the skills that you would need for putting together a mini dissertation, a project, from your literature review, a protocol that needs to be submitted for ethics, and then actually doing the work and putting together a journal article. So that's the bulk of it. And if anyone is interested, the biostatistics course makes you quite familiar with coding. So UCT uses R, and so you will pick up some valuable skills on how to code in terms of biostatistics and putting together a report. So that is transversal and very useful.
Yeah, that's great. I think, the way the world is going, that is a very, 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 very valuable skill. It's interesting, as you say, because you were talking about the practicum now, and I've come across the UCT practicum recently, and I think it's such an interesting and valuable way of getting MPH students to actually do the work of or get some practical experience, hence it's called the practicum, around public health. And the reason why I'm saying this, I mean, aside from, as I've said, my experience where I had the MPH, but then was working in a clinical context and then finding it difficult to sort of marry the two. But this is not my experience alone. There's a lot of MPH students out there who are facing sort of that chicken and egg situation where you need experience to get a job, but you can't get experience until you have a job. And so I really think the practicum is a lovely way of not only giving the students some insight and some practical experience, but it actually allows you to have a bit of a portfolio of evidence of I did this work, aside from your research dissertation, because obviously not everyone is going into research with an MPH. Some people need it, whether they're managers or working in service delivery, and they may want to use it in different ways. So I really think that's a value add to the UCT program. And from quick question, from the way you phrased it, it sounds like it's voluntary. So not everyone has to.
Yes, it's one of the elective modules in addition to the 10 that you would do in the MPH. If you want to take on a little bit more, there's opportunity there. Yeah.
Oh, great. So yeah, I think then it should probably be we should probably advocate for MPH. If you want a little bit of an edge, maybe the practicum is something to be considered. So right now you're a registrar. So if my understanding is correct, you're a first-year registrar in public health. So I know it's difficult to ask a registrar this because you rotate through different things, but a lot of people, clinicians included, don't really know what we do on a day-to-day basis. And it differs, obviously. There's some things that are the same. It obviously differs depending on where you are in the health system, what your role is. But maybe just talk us through what your current rotation is, and kind of, you don't have to, if you can't explain what you're working on specifically, but what does your day kind of look like, or your week kind of look like?
Okay. So I am currently rotating through a chief directorate that is very new to the system in terms of its packaging, the Emergency Clinical and Support Services Chief Directorate. What lives under that roof has been in the system forever and is integral to the system, but its packaging to live there is fairly new. And to give you an idea of the space, emergency medicine services, forensic pathology services, bloods and medicines, what else we have? Clinical service improvement, the Provincial Council, AIDS and TB sits there, and I'm trying not to forget anyone, and the newly developed violence prevention unit, as well as the support services, or should I say the corporate services for everyone in this space. So your people management and finance, they are also, fall under this chief directorate. It's a very varied space because there's a service arm and then there's a support arm. And included in that support arm is, well, in the service arm, there's the service priorities. So, in terms of, we're taking the life course approach. So the early to the late life course and the health challenges or opportunities to influence across that life course, whether it's HIV or TB or expanded program on immunizations. All those programs sit in this space. So it's an incredible learning experience in terms of learning some management skills, getting familiar with how budgets work. Special grants sit under this big umbrella as well. So understanding how that fits into the bigger system and how we plan for services. It's been an incredibly fulfilling experience to see how the space has been managed through these austerity measures, and to see how these directors rein things in and prioritize accordingly. Really to see them do some magic, because that's what it feels like, pulling rabbits out of hats, but with all admiration for what they do. And it's a very interesting space with a lot of learning opportunities. To give you an example of some of the things that I'm a part of or that I work with, I'm looking into developing a package of care for people with albinism and looking at how they navigate the service with specific attention to what their needs are. What are the challenges? What are the barriers? What can we assure is available at the different levels of care, and navigating those service pathways. You know, we also look at, let's think. I'm currently working on a big project that looks at, you know, looking at data, taking that, translating it into an evidence-informed decision, and using it in your workspace to really unpack how problems occur in the system and how we can respond to them using what we have. So that's been an interesting journey, and also had a lovely opportunity to work with the newly developed violence prevention unit, where the social determinants of health really came to the fore, and seeing how that links into how we provide healthcare and how the two can't be separated. That was a lovely learning experience. Yeah, so lots to learn. Yeah,
Yeah.
you know, every day it's this varied experience of attending this meeting, participating in that, and across the life course. So you could really be in one moment looking at what does child wellness mean, all the way up to, you know, how do we respond to NCDs. So yeah, a lovely learning experience.
That's great. So for those who are watching, just Chriselda is referring to a chief directorate within the Provincial Department of Health. So that's where this directorate sits, because obviously we have different levels of the health system. But to your point around the you know, doing sort of, or having different days. I was chatting to one of our other colleagues, and I was saying that this one of our colleagues is in an NGO. I work as an independent consultant. You are in the Provincial Department of Health. But what is very interesting about public health is that you find yourself pulling on different parts of your training,
Yes.
medical training, but
Yes.
also your public health training at
Yes.
different times. So you'll be analyzing data at one point, or helping them then to make a policy decision later on in the day, or involved in thinking around training, or you know, looking really at like the clinical, or discussing the clinical aspects of something, which is really great, because then life doesn't get boring, right?
It doesn't. It really, really doesn't. Yeah, and to reflect on one of those experiences, again, very grateful for having had the opportunity to participate in a practicum. The practicum that I worked on looked at alcohol harms reduction at a community level. A call for comments was put out, and basically we supported community health forum members to respond to two suggestions in terms of reducing alcohol harms reduction. And so part of what we did was take, you know, something that's quite litigious and a lot of jargon, and really make it relative and apply it to the specific communities that were present, that were interested in responding to it. And the stakeholder engagement allowed me to have a better sense of understanding when I put together, you know, in terms of the violence prevention unit, how to hold those conversations, how to frame the data. You know, it's not as simple as the data that we as colleagues would have the conversation, but then now how to use it appropriately in those spaces. So yes, drawing on all the different experiences and seeing how all the pieces fit together has really been it's a nice feeling. It's a nice feeling.
That's amazing. And I think, and I'm sure you will have this, or you already having these experiences. Sometimes you'll be doing something and you'll remember a project that you probably even forgot about, and you're like, oh, yes, I can use that tool
Yes.
or way of thinking.
Yes.
It's really interesting when everything starts converging and you start sort of building this portfolio of tools and knowledge and skills that you can use to further whatever work it is, or whatever topic that
Yes.
comes your way.
it's very convenient, very convenient as well.
Yeah, again, for, we love public health. People love a framework. So
Yes,
once
yes,
you start developing your toolkit of frameworks, you
yes,
then
yes,
you have to be
yeah.
careful that you default to them too much and you don't overburden frameworks. So Chriselda, this has been wonderful. I think my last question, that I have on my agenda
Mhm.
is, as someone who is, relatively new to the field, but, and has probably the benefit of the recent experience around decision making, maybe just reflect on what advice you would give to someone. I mean, if there was someone in your shoes 4 years ago who was kind of like, oh, I'm in clinical medicine, but like
Yes.
this is amazing, but I don't know. What is some of the advice you would give to someone considering public health as a potential career path?
Mhm. So I must say, I am eternally appreciative of the people who were able to advise me on my journey, who were incredibly supportive. And I think there's a lot of value in the advice that they gave me. So you have this passion, you are interested in, justice and equity and ensuring that services are provided at an acceptable quality. What you would want to use, what you would want your family to use. If those are the things that are integral to who you are as a clinician or as a service provider anywhere in the health system, I would encourage you to explore it. I would suggest to stay in the service while you do it, just to have that sense of, yes, this is what I want to do. Because you do have that option with courses like the diploma online and the masters, which you can do alongside your clinical time, where you would have to negotiate some academic time with your manager, but it is structured in a way to allow for that. And the reason why I say explore it alongside your clinical service is it is different to traditional clinical work, in the sense of, making that switch from your brain where again, we have our framework of how we see a patient. We take a history, we do an examination, the way we write our notes, the way, we know how to navigate the system. It takes some adjustment to then look at, okay, this is biostatistics. I'm looking at a table. What's the difference between table 1, table 2, table 3? What does this indicator mean? How, what's a p-value? What are confidence intervals? It is a bit of a learning curve. And I would encourage you to explore it and see if this is what you want to do while you are still in your space, and then take it from there. I have absolutely no regrets. And I say this, what is this? 9 months into each time. The advice that I received was, Chriselda, you can do, why go to the Reg program? You can do what you want to do in the system using just your MPH. But there's something about the Reg time that gives you this invaluable experience, like I described at ECSS, and rotations through rural or metro or epidemiology at the data center, that you wouldn't have that kind of exposure with just an MPH. So you can find, really your expertise and build on that. So yeah, I would encourage you to explore it. What suits your capability, your time management, and what you can take on.
Thank you so much, Chriselda. That was a beautiful reflection. And I think, many people are struggling with where to go next. And I think that will help them to think through the next steps. So thank you so much for joining us today. I really, really appreciate it. And we hope you will have the best public health future, all the best for your training, and very excited to see you next.
Thank you.